either way, we're going to start off with a video. Deb actually had a video that she thought would be a good transition. We both took a peek at it and kind of explaining some of the preoperative positioning things that we do. And then I'll talk a little bit about some specific patient positioning thing from both surgical anesthesia and nursing standpoints. We'll try and keep this somewhat short and sweet and a little less than boring, if at all possible. So we'll start off with this, and then I'll transition in after. This is a video that was designed by the AORN, and again, it's a pretty good transition for what we're going to be talking about later on. So.
Hi, my name's Jan.
Hi, I'm Mandy.
Hi, Mandy. Nice to meet you. I'm going to be the nurse with you in the operating room today. I have a list of questions I would like to go over with you. First one is I want to double check and make sure your armband is correct. If you would tell me your name and your date of birth.
The preoperative assessment should include, but not be limited to, the following patient factors: the patient's age, height, and weight, the patient's body mass index as it relates to girth, and the weight capacity of various operating room or procedure beds and positioning devices. The overall condition of the patient's skin. Be sure to assess the condition of the skin on the patient's back, especially for areas of redness and bruising. The presence of body jewelry or piercings. Does the patient use prosthetics, corrective devices, or any implantable devices, such as pacemakers or orthopedic implants? The presence of peripheral pulses and sensations to assess neurovascular function. Patient allergies, especially to latex or other environmental agents that may come in contact with the skin during positioning. Physical, mobility, or other range of motion alterations, such as contractures. The nurse should determine the presence of any pre-existing conditions affecting the vascular, respiratory, circulatory, neurological, or immune system. The intraoperative factors have to do with determining the estimated length of the procedure and the best position to promote optimal surgical exposure of the operative site. Given this information, the nurse will collaborate with the surgical team to determine how to position and drape the patient in such a way as to allow access to the patient by the surgeon and the anesthesia provider.
I'm going to be the nurse in the room with you today, and I'm going to be monitoring your vital signs and your oxygen, how you're breathing, all during your surgery with Dr. Jones. Can you tell me what surgery you're having today?
Carpal tunnel release on my right hand.
That is the correct spot for your surgery.
Mm-hmm.
Yes, okay, very good. What meds are you taking at home? Are you taking any meds?
I take hydrocodone for
Okay.
back pain.
Okay, and you take about 5 or 6 of those a week, is that correct?
Yeah,
That's what your chart
about
said.
that.
Okay. When we take you back and put you on the bed, I do want to put a pillow underneath your knees, and I want to make sure your back is comfortable since you do have chronic
Okay.
back pain. So I will be asking you, once we get you positioned on the table, if your position is good. If it's not, we can adjust it back there and make sure you're comfortable. Have you or anybody in your family had any problems with anesthesia?
Not that I know of.
Not that you know of. Can you turn your head side by side? Does that hurt at all?
No.
Any previous neck injuries, anything like that?
No, I mean my back pain
Okay.
is upper back pain, but my
Not-
neck's okay.
Okay. And do you have any jewelry on, or do you have any body piercings?
No, everything's out.
Okay. This is all for safety, so that's why we ask these questions.
Perioperative personnel should use proper body mechanics when transporting, moving, lifting, and positioning patients. These activities have been identified as the most frequent cause of back and shoulder problems among nurses. Manual lifting, pulling, and other patient handling maneuvers are high-risk activities for musculoskeletal injury for both the staff and patient. Most injuries to nursing personnel result from overexertion and when the person lifting or pulling has to bend forward or twist. Another high-risk activity that is frequently performed in the OR is that of lateral transfer from the bed to the stretcher and repositioning of the bed. This lateral maneuver also carries a high risk of shear injury to the patient. The following practices are suggested as a means of lessening the risk of injury to personnel and the patient. Personnel that will be involved in transporting, moving, lifting, and positioning patients should have completed training on the principles of body mechanics and ergonomics and have demonstrated competency to perform these activities safely. Use proper body mechanics when transporting, moving, lifting, and positioning patients. Transport vehicles should be pushed in such a manner that they advance with the patient's feet first. The transporter should avoid any rapid movements that may cause the patient to become dizzy. Ensure there are an adequate number of personnel available to safely transport, move, lift, and position the patient. The wheels of the transport and receiving bed should be locked during the transfer of the patient's body from one surface to the other. One person should remain at the patient's head to ensure proper alignment of the cervical spine and to protect the airway. This person, who is usually the anesthesia provider, is best positioned to coordinate the team as a cohesive unit in moving the patient. In general, surgical positioning has its greatest effects on the circulatory and respiratory systems. Many anesthetic agents cause vasodilation with a resulting drop in blood pressure. This anesthetic side effect may increase the risk of hypotension resulting from changes in the patient's position. This peripheral vasodilation results in venous pooling with a resultant decrease in the circulating blood volume. All positioning should be performed slowly and gently to decrease physiologic disturbances and in coordination with the anesthesia provider so as to protect the airway and to prevent dislodging of any physiologic monitoring devices. The major vessels that are susceptible to changes in position are the inferior vena cava and the deep and superficial vessels of the lower extremities. The vena cava may be compressed because of large abdominal masses, including a pregnant uterus, which can result in hypotension or a feeling of dizziness, along with a decrease in cardiac output. Pressure on the posterior popliteal space from a misplaced pillow or safety strap may increase venous pooling distal to the site of compression. The respiratory system may be compromised by almost all surgical positions. Supine, Trendelenburg's, and lithotomy positions in which the viscera compress against the diaphragm significantly reduce the tidal volume by 2/3. Semi-Fowler, sitting, and reverse Trendelenburg's positions, in which the abdominal viscera are shifted away from the diaphragm, are least likely to compromise respiration. Any patient with existing respiratory disease or who experiences dyspnea should have the head of the bed elevated during transport and during types of anesthesia when the patient is breathing on their own, if it does not interfere with the surgical procedure. Pre-existing respiratory conditions should have been explored in the preoperative interview. The goal is to prevent external chest compression, so the chest can move without any restriction. A combination of oxygen therapy and mechanical ventilation may be required to compensate for the effects of the anesthetic agents, analgesics, and surgical position.
Can we kill this?
There should always...
I'm going to stop this here because I notice everyone's sort of fading a little bit, rightfully so. If anyone wants to see more of that, that'll be up for 2014 Academy nomination, so it's readily available for everyone. I know Matt's a big fan of the AORN. And just your boss? Just forward? Okay. So again, patient positioning. So that was just kind of an early transition in what needs to be done or what should be done prior to positioning the operating room. So I felt that that was probably a little bit better selected than what I would have to say about it. So what I'm going to do is I'm going to go through several different positions, some of the physiologic factors, some of the risk factors, and some of the hot button topics, both surrounding anesthesia, surgery, and nursing currently right now. And then we do a couple case studies at the end, and we'll go from there. You said right here?
Chris, can I interrupt you
Yes.
just a second? Anna is around. It's very important that everybody signs in. So she's got sign-in sheets.
Is that center more, or is there?
So if
Actually, it's
everybody
okay.
is around, please sign in. Is it like that on all those things?
Yeah. No, that's fine. It's fine. Okay. So historically speaking, at least related to anesthesia, 50 years ago in the infancy of anesthesia, there were a lot of rather untoward effects or complications associated with anesthesia. Subsequently, things like peripheral nerve injury and positioning didn't receive a whole lot of attention. At that point in time, there were catastrophic brain injuries that were rather, I don't want to say common, but remarkably more common than they are today. Significant cerebral vascular disorders that occurred under anesthesia that, again, received a lot more attention. But in the last several years, those have gotten much more safer, and there's been a lot more focus, if you will, on some of the peripheral nerve injuries in patient position. There's actually a task force assigned to these particular patients, or this particular service. So because peripheral nerve injuries, and we'll spend a fair amount of time on that, because peripheral nerve injuries a lot of times don't have a great etiology because there's not a great cause for them, or a lot of times it's just kind of a who knows what happened. There's a lack of scientific evidence or lack of scientific evidence basically supporting that. Subsequently, this task force has been designed to try and see if there are more things that are kind of consequential to this occurring, okay? So again, we have a limited data on these actual occurrences. There's a lack of scientific data on it currently. And, anesthetized patients can't truly verbalize if there's a problem or if they're feeling any sort of discomfort prior to the surgical procedure. So if they're in that procedure for any given amount of time and they're in pain, we don't truly know that it's bothering them. Again, there's some physiologic variables that may change, that may kind of give us an idea that that's going on, i.e. Something related to tourniquet pressure. But for the most part, the answer, there's not much. The ulnar nerve, and we'll talk about this in a little more detail, is the most commonly injured nerve related to what we do. And 16% of all closed claim suits are for nerve-related injuries. So as I said earlier, there was a kind of an incident or an issue with there wasn't enough data or enough research going into this, but currently peripheral nerve injuries are number 2 in the American Society of Anesthesia closed claim database for litigation, number 2. The first one being intraoperative death, the second one being peripheral nerve injuries, and the third being major cerebral vascular insults. So as you can see, there is definitely some warranting here to this going on. The patient position is a collaboration between the surgeon, anesthesia, and the operating room nurses. And subsequently, it's the responsibility of those 3 disciplines, if you will. Ideally, we want to create or maintain ideal surgical exposure without compromising the patient. I'm sorry, for some reason, this isn't actually fitting into the thing. It's okay, but we'll go from there. And ultimately, above all, do no harm. We want to do this without harming the patient in any way, shape, or form. So this is a team approach. So, Dr. Lanfried actually let me take some pictures in the operating room, some of the case views. Brian Stentz actually took this picture for us. This is a picture of a patient going in the right lateral position. Dr. Lanfried, Monique, the physician assistant with orthopedics right now, Kyle's there, and I'm actually at the head of the table. I'm actually doing work, believe it or not, in the front there. So we have types of nerve injury, 3 different types: neuropraxia, axonomatesis, neuromatesis. These 3 different types of nerve injury are basically determined by the extent of the axon, which is a component of the nerve, the extent of the axon injury, if you will. So neuropraxia is just mild myelin injury, usually reversible, almost always reversible. The other 2 become progressively more variable, and then the actual nerve severing is, as you guys know, particularly those in orthopedics, that the prognosis is extremely poor in those situations. So again, these are just some of the injuries that occur here and how they're classified. Yeah, absolutely, Matt. It's getting really warm in here now too, I know. Can everyone hear me in the back? Okay, barely, okay. Can everyone see that? Okay. So the supine position is the most common surgical position we use, ideally because we access everything from that way. The anterior portion of the body, the front of the body, if you will, all the visceral organs are from that standpoint, and that's normal anatomic position. It's generally considered the safest position. However, ulnar neuropathy, again, as I said, is the most common nerve injury. It does exist in this position a rather fair amount. What we want to do ideally here, and this is just a little bit how we want to position these patients, we want the arms less than 90 degrees, padded, and the hands either in a neutral or supinated position. And by supinated, that's when the thumbs are positioned out. And this actually provides less pressure on the postcondylar groove, which is an area of the elbow, and actually decreases the incidence of ulnar neuropathy. The variations of the supine position, which I'll go into in a little bit, whether it be lithotomy or steep Trendelenburg, will be discussed a little bit more. But they have their own sets of risk, okay? And then there is something here that I think is probably worth mentioning, even though it's exceedingly rare, and that's the obesity supine death syndrome. And it is documented. There are several case reports of morbidly obese patients going from a sitting position on the OR table to supine and actually expiring. And there's several different mechanisms that are postulated as to what causes this. The first may be just, and actually it's probably a concomitant of several factors, but the first being the large abdomen basically compressing what they call the functional residual capacity in the lungs. And this is basically a reserve, a pulmonary reserve that most patients have. In this situation with morbidly obese patients, that reserve is virtually gone. So there's a pulmonary status there that gets compromised. But ultimately what they feel happens is that patient laying back causes a remarkable increase in their pulmonary artery pressure, and the right ventricle feeds into that, and they develop kind of an acute right heart failure, if you will, and subsequently the O2 consumption, the amount of oxygen that's required for the heart, basically goes up, and it's basically supersedes what their reserves are. These patients can die from this. Is it rare? Yes. Do we have a patient population that probably mimics this? Not here at all, never in the orthopedic room. That is correct. This is an axial MRI of the ulnar nerve. I'm not sure if everyone can see it. There's we don't have a pointer or anything, do you? There's in the bottom portion of that slide at roughly 6 o'clock, there's two letters. One says A and V. There's an N just distal to that, and the big X. Can everyone sort of see that? So this was a study that was done by Butterworth and Morrell out of Wake Forest University about 8 or 10 years ago, and an excellent study where they basically took patients and placed them in the supine position, and actually numerous positions, with pressure transducers all over the operating room table. So they basically got to see, during the course of a given number of surgeries, where all the pressure came, or where patients were actually exposed to pressure. And one of the things that they found, which isn't anything novel, was that the amount of pressure exerted on the ulnar nerve is pretty easily reproducible and can be excessive at times. And if you look here, the A and V is the ulnar collateral artery and vein, and the N is the ulnar nerve. And as you can see, they're in close proximity. But the X is where the pressure point almost always occurs in any supine position. And that's the pressure that's exerted almost directly either on that artery and vein or also on that ulnar nerve. So there's two mechanisms that happen here. You either get an ischemic ulnar neuropathy caused from the lack of blood flow to that neurovascular bundle, or direct compression on the ulnar nerve. These two things, or even combined the two, lead to the higher incidence of ulnar neuropathy. And again, there are ulnar neuropathies that occur postoperatively of unknown etiology that just get settled because they're there. And we'll talk a little bit about that in a minute. This is a posterior view of the ulnar nerve. And as you can see, this would be like the back of somebody's right arm. The top portion is the triceps, which has been removed, but you can see the ulnar nerve is rather large and sticks out kind of easily and somewhat easily to see. So you can see where the compression would be rather easy to go. I hope this turned out okay. I tried taking several pictures in the operating room just to kind of utilize and show what we do in the operating room. Unfortunately, trying to show these patients and things that are going on there without having any identifiable marks or facial features is a little bit tough. So this is a morbidly obese patient for an orthopedic procedure who is actually on 3 pillows and a wedge pillow, which basically puts this patient roughly 18 to 24 inches above, her head 18 to 24 inches above the operating room table. but her arm is positioned with several different pillows and blankets underneath it. And the idea here is just to show that this position where the patient is even though she's elevated, you don't want to have that arm extended like that. That can cause a brachial plexus nerve injury. And what we want to do here is to make sure that arm is, again, in a neutral position. There's less pressure on the elbow and less than 90 degrees angle. And this is actually a very good position. One of the operating room nurses did this. This is very, very well done, in my opinion. So I took a picture of that. The other stuff is just propofol running through there. This is the Trendelenburg position. I went through the archives of kind of, I don't want to say ancient, but archives of surgical positioning, and this was actually by Professor Trendelenburg. If you look closely, this is actually Ed McHugh and Chuck Mack practicing in the Dark Ages. It's also the favorite position of our urology team, Ralph Madeb, and last shot at those guys, Deb, I'm sorry. So again, traditionally this is a 10 to 15 degree head down position. Steep Trendelenburg can be anywhere from 30 to 45, and even really steep Trendelenburg can be 60 degrees. I mentioned something here, and I'll kind of jump ahead, that braces are sometimes used on the shoulders, almost like a backpack, if you will, to prevent patients from sliding off the table in ultra steep Trendelenburg positions. It's not a recommendation because there's a very high incidence of brachial plexus nerve injury. They do recommend that if you are going to use them, they sit on the acromion process, so it's not compressing directly on the brachial plexus. But that being said, it's not something we use at all here. I don't even know if we have the mechanism of doing that. But so the Trendelenburg position, by placing the patient head down, it becomes useful for exposing the abdominal contents, particularly for GYN procedures, and the appendectomy, which we do a fair amount of here. This cephalad displacement, this upward displacement, causes some rather significant changes in both pulmonary vasculature, pulmonary blood flow. It's what's called a ventilation perfusion mismatch, where you actually have, where we normally have ventilation of the lung at a given modality and perfusion of the lung in a normal upright individual. But as they lay flat, that changes. The blood flow changes as it does with gravity. And then also as the patient becomes more steep, that blood flow becomes greater in different areas of the lung that it normally isn't accustomed to. Subsequently, the oxygenation can change and you get a drop in oxygen saturation. It's rather reproducible. It's also a horrible position for patients with intracranial pressure. We don't do anyone here with expanding cranial lesions, so it's not an issue. But increased RV stress and an elevation of pulmonary artery, which we discussed about earlier. And I talked about the brace already. This is the ASA positioning and peripheral neuropathy task force, just what they're sort of recommending and what they're asking patients to do. And padding is just kind of the gold standard. The gel pads have not been shown to decrease or change any type of peripheral neuropathy per any study that I know of. I'm not saying that they're not warranted, they don't make anything worse, but some people feel that just by having these gel pads placed in and around the patient that they're immune from anything, and the answer is absolutely not. There's truthfully still risk at any given point in time. But again, arms less than 90 degrees in the upper extremities, and then again, this slide for some reason sort of blended together. The main thing to take away from this is we should be doing, as that video showed earlier, both a pre and post-op assessment just to see if these patients have any type of pre-existing conditions or what they can and can't tolerate. And this is, and I'm not here to plug regional anesthesia, but this is one of the reasons that regional anesthesia works so well, because in the lateral position where we do a fair amount of our hip procedures, even going supine in these patients, being able to ask those patients, are you comfortable in this position before we get started, is huge, because if they were asleep, they wouldn't be able to answer that, and you just really wouldn't know, aside from just pure ergonomics. And again, I'm sticking with positions that we do here somewhat routinely. We'll talk about the beach chair position in detail. I'm not going to talk about a sitting craniotomy procedure because it's just not being done. It's a waste of our time. So this is the prone position, where the patient's basically laying on their abdomen. This is utilized for spine procedures predominantly, but again, here we use it if general surgeon needs to access something on the back for a lesion of sorts. Achilles tendon repairs we've used them for, and then again in the jackknife position, which is a degree of prone position, they use it for hemorrhoidectomies. Okay. One of the guidelines from the AORN and the American Society of Anesthesia is that at least 4 people are available for turning these patients. And I think that has to go up precipitously with body mass index, because we had a 400-pound patient yesterday that almost took Cindy Perez out. We probably could use another set of hands, and Greg Branch almost took one on the beak from him too, who began to pass out as we were putting a spinal in. Fortunately, we were able to get him on his side in time. But again, is a very, very large individual, and that would have been a, probably a level 1 or 2 trauma for both Greg and Cindy had that ensued. So again, 4 people at a minimum for going prone. Chest rolls extending from basically the shoulders, the acromion, all the way to the iliac crest. And then some places that actually do spine procedures routinely have a spine table that has these pads sort of built in, where they actually leave the abdomen open for a diaphragmatic excursion. The toes should be free of pressure and either hanging off the table or placed with a pillow underneath so that they're sort of free and again not causing pressure there. And the arms again at 90 degrees and palms down. This is kind of a hot button topic in anesthesia right now. And while we don't do a ton of prone cases here, it's probably worthwhile discussing. It's called postoperative visual loss. It's a rare occurrence, but when it happens, it's devastating. And what there's a permanent either partial or complete total vision loss associated with almost exclusively with the prone procedure. And steep Trendelenburg has been associated with it, and what they're theorizing is that they develop what's called an ischemic optic neuropathy, and that ION, that ischemic optic neuropathy, occurs because the intraocular pressure basically supersedes what the vascular pressure is within the eye. And I'm sure the ophthalmologist can discuss this in much better detail than I can, but it is an occurrence, and it is something that they're seeing more and more with these larger spine procedures. But the risks really aren't conducive to what we do here. Prolonged surgery, and 94% of these patients that actually registered with the anesthesia closed claim database, all those procedures were greater than 6 hours. Pre-existing conditions, which basically is virtually every patient that comes to the operating room: coronary artery disease, diabetes, obesity, and then an elevated estimated blood loss. So again, a blood loss greater than 44%. When you think about that, that's really, in a normal individual with a 5 to 6 liter estimated blood volume, that's roughly 2 to 2.5 liters. It's a lot of blood loss, but again, it's an occurrence. Lateral decubitus position. If you look real closely, we have Momo. I think she's actually standing up completely in that picture, helping position this patient. This is an excellent job of this patient being in the right lateral position. This is for a total hip arthroplasty. Again, this slide, I don't know if it's the sun coming through that's making that a little, because the slide's actually rather crystal clear. Both arms are positioned less than 90 degrees. They're padded, and they're in parallel. The head, which I couldn't show here just for obvious reasons, needs to stay in a completely neutral position. Even that head slightly, lying down a little bit can cause a stretch injury on the brachial plexus, and again, kind of limiting ourselves to having another one of those issues. So again, this is most commonly used for thoracic retroperitoneal, and here, we use it quite a bit for the hip arthroplasties. The patient's lying on the non-operative side. One arm is suspended on the arm board in parallel, like we talked about. The dependent arm also just parallel with that one on the OR table arm board. A pillow or additional padding with the down leg flexed. And then a chest roll is recommended. Now, we don't use that here. And I don't have a great explanation for it. It's not a guideline. It's not. I just want to say it's a soft recommendation by the American Society of Anesthesia to use a chest roll for these procedures. We have not, to my knowledge, know of any brachial plexus nerve injuries associated with the hip procedure. So I think what we're doing is just really excellent positioning of that down arm is probably almost as important, if not more so, than having a chest roll in place. But it's basically either an IV bag or a roll that's placed under the axilla as the patient's on their down side. And some of the complications associated with this. So again, as you can imagine, we talked about just laying the patient flat, laying them on the side, the same thing occurs. We have blood flow going to one lung and greater than the up lung. So that causes, again, that VQ mismatch we talked about. Neck flexion can cause a brachial plexus injury, like we talked about, and always check the eyes and ears. The long thoracic nerve is a rare but potential complication with the lateral position, and it causes a winging of the scapula, which is shown here. And basically it controls the serratus anterior muscle, and that scapula basically becomes, I don't want to say fixed, but it's in that position. They don't have the ability to bring it back medially. So I had to put this picture in. This is another one from the archive. I don't know if Michelle and Courtney have any comic insight to this. I was hoping Rich Edwards would be here. This is the old lithotomy position for birth. And I know there's a joke in here somewhere, but I'll avoid it for now. The lithotomy position, again, utilized for GYN procedures, urologic, general surgery. Again, patient supine, the legs are 90 degrees. In low lithotomy, the legs are positioned at 30 to 45 degrees, and in high lithotomy, it's roughly 60 or greater. A little higher risk of sciatic nerve injury with that. Legs should be padded, and then the most important thing to take away here is that pressure on the fibula should be minimized as much as possible, either with padding or with changes in leg flexion, because the most common lower extremity peripheral nerve injury is the common peroneal nerve injury. And then one more thing, this came from the AORN, is that legs should be elevated simultaneously to avoid dislocation of the hip joint, and then it helps prevent some rotational stress on the spine. I talked about the common peroneal nerve injury. All right, so this again is kind of a, and I'm going to talk a little bit about this at the end. This is kind of another hot button topic, if you will, in anesthesia and surgery regarding this position. This is, shoulder arthroscopies are one of the most common procedures done in the United States today. And the majority of them are being done in the beach chair position. And there's a fair amount of data showing that, that there are some cerebral events that can occur in this position. And we do, in my opinion, quite a bit of shoulder procedures here, so this is something we should probably look at a little bit more in detail. Again, it's most commonly utilized for shoulder procedures. Again, I'm not going to talk about sitting procedures for craniotomies, we just don't do them here. Patients positioned at roughly 45 to 60 degrees, and really truthfully probably a little bit higher in most circumstances. The non-surgical arm should be less than 90 degrees and padded. The face, head, neck should be in a neutral position, and a pillow under the knees to prevent lower lumbar pain. And this is a position of a patient that we were doing a shoulder arthroscopy on, an excellent job of positioning the right non-dependent arm or non-surgical arm. And this patient actually, as you can see, everything's in perfect symmetry. There's no pressure on the elbow, and it's actually supplementally padded. And what's important here is that the arm and the shoulder are not being displaced inferiorly. There's no sag on it, there's no stretch on it, because that again can probably lead itself to a brachial plexus nerve injury again. I know that sounds like kind of a redundant thing, but it's really probably one of the greater risk factors. Complications associated with this: hypotension is the most common, secondary to venous pooling. We talked about that in that video that Deb had earlier. Venous air embolism is almost entirely, it's rare, and it's almost entirely associated with open head procedures. It has to be something greater than the level of the heart, so with shoulders, it's virtually non-existent. Brachial plexus and ulnar nerve injury are there, and then the cerebral vascular events, and this is the point I think I want everyone to take home today. There have been documentations of rare but catastrophic neurologic events that have occurred in the beach chair position. The incidence is low. There's some debate in the anesthesia literature about whether it's a parallel or siphon circulation. That's not important here. But what is important is that, you know, normal autoregulation, basically the normal mean arterial pressure where we consider blood flow or cerebral blood flow to be maintained, was always thought to be somewhat low. And some of the new data is saying that maybe it should be kept a little bit higher. So these lower limits of autoregulation need to be revisited. The other thing that needs to be taken away here is what we measure, and this is solely an anesthesia thing, what we measure in our blood pressure cuff on the arm is it should be slightly higher than what we actually measure what would normally be going on in the patient's head. Because as gravity flows, as blood flows away from the heart, the hydrostatic pressure gradient changes. So subsequently, there's roughly an 8 to 24 or 25 millimeter of mercury difference. So for example, if we have a mean arterial pressure of 60, which is where we like to see it to try and keep a bloodless field for at least I like to keep it for a bloodless field for a shoulder arthroscopy. If it's 60 there's a very good chance that that mean arterial pressure in that person's cerebrum, the cerebral blood flow, is roughly 45. It's pretty low. And if you're sitting at 50, you could be sitting at 35. So this is where some of the debate occurs. So current research, again, this rare incidence, 0.003% of these patients suffer these permanent disabilities associated with this. What they have found is there's this regional cerebral oximetry that basically happens almost in 20 to 50% of patients that undergo the beach chair position. So it's a change in oxygen saturation in the blood. The amount of oxygen in the blood in the brain at a given point in a given area decreases. What was interesting, I just threw this in as a side, there are certain patient positions that warrant themselves to be nauseated, or surgical procedures. GYN have a very high, laparoscopic GYN procedures, but the shoulder procedure has a very high incidence of post-op nausea and vomiting. They found that of those patients that had post-op nausea and vomiting, almost all of them had a regional change in blood flow associated with the beach chair position. So One study by Murphy et al. Showed that patients who had general anesthesia only had a 57% incidence of this regional blood flow changing, or this regional oxygenation changing. Patients with regional anesthetics had none. More studies, patients in lateral decubitus position, which I don't think that's really a common practice to use that procedure for that position for shoulder arthroscopies, but that versus the beach chair, they had what's called the cerebral desaturation event, where the oxygen saturation in the cerebrum dropped. 80% in the beach chair, 0% in the lateral decubitus position. And then looking at these patients with regional versus general anesthetic, it's less than 1%. So this is the study that I think is of really significant importance. And this was a study that came out of the Journal of Bone and Joint Surgery in 2012. They took 52 patients for shoulder arthroscopy in the beach chair position, and they used EEGs to monitor possible ischemic events. So not regional blood flow changes, not regional oxygen saturation changes, but true cerebral ischemic events. They had 3 incidences, and they were transient. And they were transient because they were actually treated with an elevation in blood pressure by the anesthesia provider. So 3 events. No adverse events were noted post-op. They utilized the mini mental status exam for this particular way of assessing post-op cognitive dysfunction. 27 patients, so roughly half, showed no evidence of ischemia with blood pressures or systolic blood pressures less than 90. This study concluded that greater amounts of hypotension may be better tolerated than previously recommended. I have a slight problem with this study in that if we consider 3 out of 52, which is roughly 6%, to be safe to be in a hypotensive situation, for a true ischemic event, there may be some flirtation with another one of these events occurring. So again, this study was very well done, but from an anesthesia standpoint, we have a slight problem with keeping patients that low for that long, especially in the event that, again, 6% ischemic event, in my eyes, is relatively high. So just an aside. So without further ado, does anyone know what this is? I know Matt does. This is the obligatory anesthesia fuck around time. So pardon my French, but this was coined by surgery. I've heard it all over. And I practice at several large university hospitals, and there's no question in my mind that this exists, that some of these people are just, they're fucking around in between cases. But ultimately, there's some point in time where some of the screw around time or this extra time that anesthesia needs may actually be warranted. I'm going to talk about a couple case reports here where it was probably warranted that we paid a little more attention to something else along the lines here. So this is a 78-year-old male who had a troch nail, if I'm not mistaken, and this wasn't a patient of mine. And the patient elected for a spinal. The spinal was placed and the patient was positioned on the fracture table. This took place at a small community hospital in upstate New York, outside of up north of the Adirondacks. I used to moonlight up there for a week a year when I used to work at the University of Rochester. 30 minutes into the procedure, the surgeon begins reaming the femur, and then you can hear this extremely loud yell. It was a 3-bed OR, very small place. Apparently the patient fell off the table during the middle of a femur fracture revision. Completely off the table, on the floor, open leg, the whole shooting match. All OR staff was paged to OR1. And for some reason, again, this isn't showing up, but the patient ultimately only suffered a minor laceration of his head, he had a shoulder hematoma, and I think he had a scrotal laceration. So we talk about sentinel events, we talk about risk management, we talk about these bad events that occur, and ultimately there's a kind of a Swiss cheese phenomenon, if you will, a Swiss cheese management here, where basically there's all these holes in the system. It can start in ambulatory, the patient didn't receive adequate IV antibiotics, something else wasn't done, to as they're going into the room, something's missed, anesthesia doesn't document something clearly, there's, something happens intraoperatively that's not clear, post-operatively an event occurs. So you have these sort of holes, and all of a sudden they line up. And as these holes line up, it's a straight shot for bad patient outcome. And that's what happened here. These case scenarios I'm going to talk about are going to be, nothing's catastrophic, nobody died, and there's plenty of those to go around. But these are ones that are just simple screw-ups that shouldn't have happened, and really and ultimately are blank checks for both the hospital, the surgeon, and the anesthesia provider. When I say blank check, that means that the attorney can basically determine what number they want on their and you're going to have to sign off on it because this is a big, big deal. So this patient ultimately, I don't think there was any litigation associated with this because there was really no major harm. And the patient, I think the patient actually had the femur somewhat secured before they fell, so I don't think there was any major deficit after that. This is a 62-year-old male for an anterior posterior cervical fusion. This is a right-hand dominant medical professional. And he was intubated. 16-gauge peripheral IV was placed on the right wrist and after induction, and the anterior approach proceeds. He's tucked, his arms in neutral position by the nursing staff. The procedure goes 3.5 hours. They get into it. There's 3,500 of fluids administered that were administered under pressure via a pressure bag, and there's about 650 of blood loss for this procedure. So after an anterior procedure is done, they unprop the patient and they flip the patient prone to proceed with the posterior portion. As they do this, it's noticed that the right arm of this patient is extremely edematous, 2 to 3 times the normal circumference that it was, and it has blisters all over it. What ultimately ended up happening was that there was an infiltration of the IV when the arm was tucked. The hands weren't neutral like we talked about. They were sort of, pronated a little bit and kinked. The IV was kinked, was run under pressure, which was a mistake from square one, and basically infiltrated the arm with roughly 3,500 cc's of fluid. The patient actually ended up having to go an emergency fasciotomy, and subsequently had some some deficits in their hand post-operatively for several weeks, if I'm not mistaken. So recovering from an anterior posterior cervical fusion in and of itself is misery, but to do that with kind of a bum right hand that you're dominant with probably makes that a hell of a lot worse too. So again, another screw up from start to finish. And the last but not least, this is a 42-year-old patient, otherwise healthy, for uteroscopy and stent placement. Patient's placed in lithotomy position. Surgery takes about 45 minutes. Patient does fine. At the end of the procedure, they're beginning to bring the legs down, table legs coming up. Anesthesia notices that the pressure jumps, greater than 200. The heart rate's 120 at emergence. Really we always see a little bit of an elevated, sympathetic response on extubation, but this was a little bit more obtuse. And as it turned out, the patient who was positioned in the lithotomy position with their hands not supinated or at neutral, they were positioned pronated with their palms down. The fingertips were actually crunched into the OR table. And that patient suffered several different ischemic events and crush injuries in the distal fingers. Again, there's that Latin term, I think it's recipro loquitur or something like that, that basically the Latin for the thing speaks for itself. This is a blank check. Any hospital administrator will have heartburn over this for a long, long time. Again, this guy was actually a construction worker, worked with his hands, and not anymore. So that's really it. I'd like to say a special thanks to Dr. Matthew Lanfried for allowing me to present in his operating room. This picture was actually taken at the gala last year, if I'm not mistaken. Dr. Ralph Madeb during his first year of residency. And Jason Donovan, this was taken on the way in yesterday from UR, so thank you. Any questions? Awesome.